Hi everyone, my name is Hayley Evans. I'll be presenting on behalf of my co-authors our paper Perspectives on Integrating Trusted Other Feedback and Therapy for Veterans with PTSD. In the presentation today, I'll first give you a little bit of background on PTSD and trusted others. For your reference, a trusted other is anybody who's involved in a veteran's care. It could be an adult child, a spouse, or a close friend. I'll go over our methods, our results of what we found that trusted others could potentially see in veteran behavior out in the real world and report in to clinicians as well as the veterans for use in a clinical setting, and then the implications of this study for not only PTSD but for chronic conditions more broadly. Before diving into the study, it's important to help you understand what PTSD is and what those symptoms look like, because that's what we envision trusted others might be able to see out in the real world. So the first of the symptom clusters is hyperarousal, which is things like the body being in high alert. There's trauma re-experiencing, which is intrusive memories and nightmares. There's avoidance behavior, so avoiding trauma-related situations, thoughts, and feelings, and negative alterations in thoughts and mood. In our study, we choose to look at veterans with PTSD specifically as a case study because veterans are disproportionately affected by PTSD. They are also reluctant to seek care, despite its proven effectiveness. And of the 50% of veterans who are affected that do seek care, only about half of those will receive what is considered to be minimally adequate treatment. Much of therapy takes place outside of the clinical office setting, where patients do homework or apply what they've learned in a real-world setting. And so we thought perhaps we could leverage trusted others who are close to the patients and would see this behavior in order to provide feedback regarding that behavior for use in a clinical setting. In order to explore the inclusion of trusted other feedback in the clinical setting, we explored the following research questions. What are ideal feedback text experiences as veterans progress through clinical treatment for PTSD from the perspectives of each of our participant groups? How can we design the social sensing system with these findings in mind? And how will these groups perceive that this will affect patient engagement in clinical decision making? We utilized a mixed methods, two-phase study, first where we worked with clinicians to have them develop questions that could be asked to trusted others that they would find useful and usable by reformatting a PCL5 survey, which is typically used for veterans to gather self-report, as well as doing a semi-structured interview. From there, we developed a storyboard, which was shown to veterans and trusted others that depicted the idea of the social sensing system. We also surveyed these individuals after they saw the storyboard and did a semi-structured interview to determine if this would be something that they would want to use, and if so, how and why. And then finally, we did data analysis on all of this data, utilizing thematic analysis and basic descriptive statistical analyses on the survey responses. This is an example of the storyboard that was shown to trusted others and veterans. In it, we see that a veteran decides not to enter a fair because they don't want to be around crowds, and then the following day, the trusted other receives a text message asking for feedback about the veteran's behavior that week. We found that 27 of our 30 participants wanted to use the social sensing system as a part of their trauma-based therapy process. However, it's important to note that this could be indicative of self-selection bias. Regardless, we do believe that the social sensing system could function well in relationships between trusted others and veteran patients, where that relationship is already strong and there is a high level of communication, and likely that trusted other is already involved in the veteran's care in some way. We do talk about the symptoms that veterans, believe trusted others could see, that trusted others believe they could see, and that clinicians would want to see in our paper. And we divide them into 4 symptom clusters that relate back to what I had showed earlier in the presentation. We do talk about trauma re-experiencing, avoidance behaviors, negative alterations in thoughts and mood, and hyperarousal. And for brevity, I'm just going to give an example of hyperarousal and what we saw here. So hyperarousal behaviors were determined to be observable by trusted others and of interest to clinicians, who actually ranked 2 of the questions regarding hypervigilance and startle response in their analysis of the PCL5. Interestingly, veterans believed trusted others were most likely to witness these behaviors, while trusted others only believed that they were somewhat likely to see them. This could also be sleep patterns too. And in one of our semi-structured interviews, our trusted other told us, it's so drummed into them in the military to be hypervigilant, especially those with PTSD. It seems to always be with them. You can be cured of it, but they are hypersensitive to particular vehicles, particular people, sounds, smells, all those different things. And we did hear this from many trusted others, that they were able to see certain instances that would cause a state of hyperarousal. We found our 3 participant groups had specific ideas around the logistics and implementation of the social sensing system, including text message cadence, feedback formatting, perceived use of feedback in therapy, and data access and control for all groups. For brevity in this presentation, I'm going to talk about perceived use of feedback in therapy. Clinicians felt that using trusted other feedback in therapy could help demonstrate progress over time in conjunction with other measures. It could also help to verify self-report and be used as collateral information. And finally, clinicians felt that if they believed they could trust the self-report, they could use this information to tailor treatment, because perhaps trusted others would be able to see behaviors out in the real world that they could not. Veterans wanted to use this feedback in therapy as well, if it was being collected and they had put the effort into it. However, they did mention that this could be challenging. They said it might be useful to delay talking about it or to use it at a high level. Veteran V2 said, I would want to review this information in the presence of a doctor. If I was in a negative mood and it was early on in therapy and I learned, hey, your trusted other is out there saying something's happened, then I might act out or do something silly. In our paper, we provide several design implications which can be extended from PTSD to chronic conditions more broadly. We suggest emphasizing the familiar and positive rather than focusing on symptoms of any kind of condition. To control trusted other participation and content, and to give the patient some say in this. High-level feedback from all parties for indirect social support, because a drilled-down detail for a clinician and not a patient may not feel appropriate. To constantly gauge the relationship impact and see what kind of impact this might be having on a trusted other and a patient. And then finally, customizing the cadence of feedback to fit the trio, the clinician, the patient, and the trusted other, to make sure it is suiting everyone's needs. Our study provides one of the first investigations of social support in clinical practice for veterans. We also explore each of the points of view of clinicians, trusted others, and veterans, and provide a conceptual design of the social sensing system. And finally, we explore the balance of power and politics utilizing Davis's mechanisms and conditions framework.